Go ahead, Katie.
Okay. Hello, everyone. Good morning, good afternoon, and good evening, and welcome to the Family Planning and Immunization Integration webinar. This webinar is the latest in a series of webinars on high-impact practices in family planning. We'll just give it about one more minute as attendees start to roll in, and then we'll get going. So I am Catherine Mimno, and I'll be today's moderator. This HIP webinar was developed in partnership with the Family Planning Immunization Integration Working Group, IBP, and FP 2020. I'm one of the co-chairs of the Family Planning Immunization Integration Working Group. So I'll start us off with a brief introduction of the working group and how you can get involved before we dive into today's topic. Next slide. So the Family Planning Immunization Working Group was launched in 2010 with a goal to share lessons and guidance from field experiences and research initiatives on optimal ways to link or combine family planning and immunization services in facilities and communities so that the reach and effectiveness of both interventions are enhanced. The working group facilitates a community of practice and has provided technical leadership for the development of this HIP brief that we'll talk today, as well as other briefs on other aspects of integration. In 2013, the working group launched the FP Immunization Integration Toolkit on the K4Health site, where you can reach a variety of sources and information related to integration. These links will be available in the presentations following the webinar, and they're also in the chat box now if you want to follow along during the presentations. Next slide. The working group meets twice a year in the DC area with remote participation welcome and encouraged. In addition to the main working group, there are 3 subgroups which take on different aspects of the work: country engagement, monitoring, evaluation, and research, and global technical leadership. We've recently also been collaborating with the Maternal, Infant, and Young Child Nutrition and FP Integration Working Group on reducing missed opportunities across the full continuum. If you're interested in learning more after today's webinar, please visit the K4Health site, join the community practice, or attend to the next meeting, which will be sometime in December. Currently, planning is underway. Next slide. So we've got a great agenda for you today. We'll start with 2 presentations that are showing more of the global perspective, including an introduction and overview of the HIP brief and the new evidence repository and development. Then we'll discuss opportunities for integrating family planning and immunization services. Then we'll shift gears and hear more about on-the-ground implementation lessons learned with in-depth country experience in integration and scale-up from Liberia and Mozambique. Finally, at the end, we'll have plenty of time for question and answer. Go ahead, next slide. So we hope that you leave today's webinar with a better understanding of the FP Immunization Integration HIP brief, new advances in the field, and lessons learned from implementation challenges and successes on the ground. We'll have, as I said, plenty of time for question and answer at the end. So as you listen to the presentations, please type your questions into the question box. You'll see that it's one of the gray boxes on the right-hand panel of the control panel. This webinar will also be recorded, and all presentations will be available for participants. Additionally, if you look at the handout section, again on the control panel, you'll find a copy of the HIP brief in English, Spanish, French, and Portuguese. Next slide. So we've got a wonderful panel for you today. We've got Sean Mellor-Shea from USAID, Niapu Taylor from Jipaigo, Liberia, Riaz Mubarak Ali from Pathfinder Mozambique, and Rebecca Fields from JSI. Next slide. So to kick us off today, we have Sean Mellor-Shea, who will be presenting on the HIP brief and evidence repository. Sean is a senior technical advisor for utilization of best practices at USAID. Take it away, Sean.
Thanks. So I'm delighted to be part of this webinar. It's a lovely fall morning here in DC, and I'm sitting across from Rebecca. And I'm here to share with you a little bit about where this particular practice sits within the broader HIP work that we do, the work on high-impact practices in family planning. If you don't know about high-impact practices in family planning, I would encourage you to go visit the website. I think that is on the materials that you have resources to. Can you go to the next slide? Okay, this is the HIP brief, which was actually published a few years ago. I'm going to talk a little bit more about that in a few minutes. The practice that we're talking about is offering family planning information and services proactively to women in the extended postpartum period during routine child immunization contacts. And I want to emphasize a couple of things here in that definition that are important to think about. One is that in terms of this particular practice is a service delivery practice, which means that in order to be considered actually implementing this HIP, family planning services need to be offered either on-site, co-located, or within the immunization service itself. And it needs to be proactively offered. So you need to be screening women to see if they are interested in learning about family planning as part of the routine immunization process. That's what this HIP is. If you're only offering messaging, counseling around family planning, then we consider this an SBC, or a social behavior change communication activity. I'm going to talk about that in just a second. Can you go to the next slide, Otto? So just to give you a little bit more of a visual about that difference, the HIPs actually categorize practices into three large buckets. The first one is the enabling environment, and you can see the definition here on the slide. It's basically those systems level investments that you need to be focused on in order to make things work within the general health system. Then we have service delivery. So this involves really how family planning services, contraceptives, are provided to clients and people that are interested. The green box here is social behavior change. This is an area we've only just begun to work in, and we're trying to articulate what the practices are that we invest in to actually change client behavior around contraceptive use. So that's why we make the distinction between if you are providing contraceptives as part of the integration experience. That's what all of our service delivery integration, that's a key component. When we talk about integration, we're talking about actually offering those services as part of the practice. Whereas if you're only talking about messaging, it would fall in this green box, and we look at the evidence in a different way, and we present it in briefs related to that. And we are currently working on a brief on interpersonal communication, so that's where if you're only offering messages, that's where that evidence will be put together and communicated. Can you go to the next slide? So I also wanted to highlight another categorization that we do with the high impact practices, and that is we try to distinguish between the consistency and the strength of the evidence base for any particular practice. And so we've distinguished between things that we consider proven. That means that we know we have enough evidence to show that they are likely to be feasible within a variety of settings. So we have seen that they have been successful or effective in a variety of contexts. And we also look at, in terms of effectiveness, we want to look at the effect on contraceptive use mainly as our main outcome measure. We also look at things like fertility, or other proximate determinants of fertility, but we rarely have evidence on that. Most of our evidence actually comes from the effect on contraceptive use. So in this particular practice, our evidence is a little weaker. We don't have quite as much documentation of how effective or how impactful this particular practice is on contraceptive use. Can you go to the next slide? So this is the table from the current brief. You can find it linked to the website. So this was when we actually published the briefs. That was in 2013. You can see we actually only had 5 studies that documented the effects on contraceptive use. And you can see of those 5 studies, we had 3 that showed a positive effect and 2 that were not statistically significant. We also wanted to make sure that, or we wanted to see what the effect on immunization utilization. I think Rebecca may talk about this a little bit more, but we want to encourage you, if you are actually documenting the effect of this practice in whatever context you're working in, that you're collecting information not only on contraceptive use, but also making sure that you're not having a detrimental effect on routine immunization. So can you go to the last slide? So I wanted to just say a few words about the evidence repository. This is a new activity that we're starting under the high impact practices, and this is an effort to update the evidence base in a more timely manner. So rather than having to wait till we update the brief itself to show what new evidence we have on particular practices, we're exploring the idea that we could make space on the website to actually show new evidence as it becomes available. And our first test case is actually the practice of integrating family planning into immunization services. And I'm just giving you, it should have actually a draft watermark across this slide because we're still in process. But as you can see here, we have a number of new studies that we're excited to share the evidence on, all of which actually looks very positive, so that's a good sign. We're still waiting for more information on a few of these studies, but I have included the full citations, so if you're interested, you can go yourself and see the publications. That's it for me. Thank you.
Great. Thank you so much, Sean. Excuse me, this is Rebecca Fields, and I'm going to spend the next few minutes talking a little bit about the immunization program parameters and the types of opportunities that are provided through immunization to support this promising high-impact practice. Next slide, please. Next slide, please. So I just want to take the next few minutes to give a little bit of an overview of what is the opportunity provided through immunization, what are the parameters, and also what are some of the interests, priorities, and concerns on the part of immunization program staff, both at country level and at global level. So what is the opportunity? The opportunity is to use the platform of child immunization contacts to provide information and referral and services ultimately to the mothers who bring their children for vaccination, who are also themselves postpartum women, so to refer them for family planning services. Now, making this an idea a reality requires understanding some key considerations about this immunization platform, such as how many children and their mothers, the postpartum women, can be reached through this platform. Who are they? Who can be reached and who maybe is not as well served by this platform? When can they be reached? And how can they be reached in a way that is good for family planning, hopefully is good for immunization, and at least does no harm for immunization? And I'll get into that in a moment. Next slide, please. So this is a standard slide that WHO and UNICEF put together each year that summarizes performance in immunization across all countries, and then with the trend lines in different colors there, the coverage in different geographic regions, different WHO geographic regions. The indicator that we standardly use in immunization is a third dose of diphtheria, tetanus, pertussis-containing vaccine, that is DTP3. That's our standard indicator. And a couple of things I just want to highlight here. One is you can see that coverage is really quite high. For the past several years now, immunization has reached about 85–86% of children, and then presumably their mothers as well, with at least 3 doses of this vaccine, meaning at least 3 contacts with those women in the first year of life. But there are a couple of other things to note here as well. One is that coverage has really stagnated over the past several years. We've had a hard time pushing through and getting to those most vulnerable children, actually. And we also see that coverage is lower in regions that have lower levels of infrastructure. So moving on to the next slide, please. What we're seeing here is a little bit more information on who it is who can be reached through immunization and where we're still facing some issues with equity. This slide shows DTP3 coverage disaggregated by highest and lowest wealth quintiles in about 16 countries that have conducted DHS surveys over the past 5 years or so. And what you can see here is that there are some countries, such as Malawi, Rwanda, Uganda, that have achieved very high levels of coverage, and they have done it in a way that is highly equitable. This is a very strong platform in these countries. By contrast, we see huge disparities in immunization coverage between lowest and highest wealth quintiles in several countries. And just noting a few here, Ethiopia, Nigeria, Pakistan, the disparities in coverage between the highest and lowest wealth quintiles are very, very strong. In Nigeria, for example, coverage is 11 times higher in the richest wealth quintile compared to the poorest wealth quintile. So in thinking about programming and how strong a platform child immunization may be for family planning, this is the kind of data to take a look at and think about in designing program interventions. Next slide, please. So, when can women be reached for family planning through immunization? Well, this is a function of, excuse me, of the routine immunization schedule in each country. And in most low-resource countries, including all of USAID's family planning priority countries, with the exception of Indonesia, the schedule is as follows. There are basically 5 routine immunization contacts in the first year of life, at birth, 6, 10, and 14 weeks, at 9 months, and then in the second year of life, usually at least 1 immunization contact somewhere around 15 and 18 months. Those are the designated times in the schedule. The actual time for vaccination is often later than that, but that's not desirable. It's really critical to avoid the prolonged exposure to disease. So we really work very hard to try to make sure that schedule is respected. Next slide, please. Now, next question is, how can women be reached through that platform of immunization? And in designing interventions, it's important to think about both the positive and the negative effects for family planning, but clearly for immunization, for this platform that is to be used here. On the positive side, the effect may be to secure additional support for immunization by using it as a platform to serve other programs. It sort of broadens the utility of immunization, makes it that much more important, and perhaps may attract that much more support for the program. And of course, the really important one is that by increasing convenience to caregivers through one-stop shopping, people-centered programming that can increase can increase convenience, that can also increase the utilization of those services and vaccination coverage, which is really what we're seeking in immunization programs. Some possible risks exist, however, as well. One is that there is the possibility of deterring those mothers who readily accept immunization but are perhaps not so prepared to accept family planning during that same visit. The second one, which is the one of bigger concern, is creating confusion that immunization, EPI, Expanded Program on Immunization, is actually a masked attempt to provide family planning and sterilize women or children. And unfortunately, this is not just a conjectured risk. Next slide, please. There are many, many, many instances, extensive documentation of rumors. This just shows in Africa. Many instances of rumors that vaccines are actually a masked attempt at sterilizing children. This particular slide is from one particular paper that, I'm sorry, the reference is cut off at the bottom, but you'll see it on the electronic slides, I believe. This shows several examples over the past 30, 40 years now, just in Africa. Next slide, please. However, there are additional examples as well. In the Philippines in the 1990s, more recently in Madagascar in 2007, in Pakistan in 2013 and onward from them, in Kenya even as we speak. Often these rumors come up in connection with mass vaccination campaigns, these high visibility events that attract a lot of attention. Sometimes they are externally funded, and they draw a lot of attention to them. And often as well, we see that these rumors take off when there is vaccination of women of childbearing age or of pre-adolescent girls, for example, with HPV vaccine. Next slide, please. And in some instances, the repercussions of these rumors have been very, very severe. So here on the left-hand side, Pakistan, polio instances, 7 killed in anti-vaccination attack. There have been 5 examples of deadly attacks on polio vaccinators over the course of about 3.5, 4 years, where there was conjecture that polio vaccination was a conspiracy to sterilize children. Something of the same nature happened in Nigeria back in 2013. And very, very recently, just during the past few weeks, we've seen that the key opposition leader in Kenya has joined the Catholic Church in opposing tetanus toxoid vaccination because of claims that this is actually sterilizing women and girls, even though, of course, that's clearly not the case. Next slide, please. So what can we do about this? Clearly, there are ways of mitigating the risks and making sure that this platform is appropriately used to serve multiple purposes. So the first area is to reduce the risks by designing approaches that really work for both programs, both immunization and family planning, that recognize where there may be risks and address them. For example, by not trying to provide family planning during mass vaccination campaigns. Not a great setting for it for either service, actually. These are intermittent campaigns. They're crowded, chaotic environments that don't provide opportunities for privacy and confidentiality. Certainly involving immunization staff at multiple levels in designing the interventions is very important for gaining support. Then, as Sean was mentioning, actively monitoring the effects of such integration for both family planning and immunization is a way of checking and making sure that this is an effective type of integration, and then sharing the data that demonstrate gains with all audiences, both family planning and immunization audiences is important, as well as overtly recognizing that if there are certain areas where it hasn't worked as well, they need improvement, they need more attention. And then finally, sharing that experience actively, engaging country-level immunization staff themselves in sharing their own experience with integration can be a way of increasing the support for such integration. And then disseminating the findings and implementation experience, not just the findings, but how it's done, to both family planning and immunization audiences helps create a shared understanding of how such approaches can be effective. Next slide, last slide, please. So in conclusion, routine immunization contacts are excellent opportunities for family planning, referral, and services, but they do have certain parameters and limits that need to be broadly understood. Win-win models for family planning and immunization integration should be designed with input both from family planning and immunization staff and monitored for their effects on both services. And finally, it's in the best interests of both immunization and family planning to make sure that that platform of child immunization remains strong and vital to both programs. This is good for the programs and ultimately for the good of women and children. Thank you very much.
Wonderful. Thank you so much, Sean and Rebecca, for those great presentations. Next, we'll shift gears a little bit from the global perspective to hear more about in-country experiences with integration and scale-up directly from the countries. So first, we have Nyapu Taylor. Nyapu is a technical advisor for Japaigo, Liberia, and will be presenting on lessons learned from implementation of FP immunization integration there. Take it away, Nyapu.
Thank you very much. I'm going to give Liberia FP immunization integration country experience, which I will give a background. I started with MC experience that MCSP built on to implement the projects in these countries. Next slide, please. Next slide, please. Hello? Hello?
Nyapu, I think there's just a little bit of the delay. So right now we see the MCHIP MOH approach with the map. So when you say next slide, we'll go on, and then it may just take a minute to get you there.
Okay, thank you very much.
No
the MCHIP approach was a combined service model that was used whereby at the immunization site, they were taught to give one-on-one family planning messages to the mother. And if the mother is interested in going for family planning services, referral card was given to the mother to take to the family planning provider. This was a pilot project that was implemented in 10 health facilities in Bon and Lofa. We have 1 hospital and 4 clinics in each county, and was done along with the Ministry of Health. It was not a research, but it was a design that was used that after the implementation, MOH could use it to implement in other facilities within the country. And the pilot phase lasted from March 2012 to November 2012. Next slide, please. Okay, as I said earlier, women bringing their children to the vaccinators were all giving family planning messages on family planning. And if they are interested, they will refer to the family planning provider. Job aids were provided for the vaccinators because the messages given, we wanted it to be the same because they were not clinicians. So we had special messages for them to give to the mothers. And these messages were developed based on a formative research assessment that was done to identify about the stigma on postpartum mother taking contraceptive. And posters were placed to or in the facility, reinforcing the messages to the mother. And clients, after giving the family planning messages, that decided that they were not going for family planning services, they were giving leaflet to take home, which have some of the benefits of family planning to the child, the mother, and the father to go think over it. And if they are interested, they now will come back to the family planning provider to receive the family planning service. Next slide, please. Okay, as you can see on the graph, there was an increase of 90% of new contraceptive users in Lofa, where in Bon we have 73% increase. Next slide, please. Okay, of the new contraceptive users that we had in Lofa, 34% of them were those who accepted referral from the vaccinator to the family planning provider, whereby in Bon, 44% of the 93 accepted referral from the vaccinator to the family planning provider on the same day. Next slide, please. When it comes to immunization funding, we noticed that it's a bit less clear. But in pilot studies, the number of Penta 1 and Penta 3 doses increased during the implementation period compared to March to November 2011. In Lofa, the pilot facility administered 35% more Penta 1 doses and 21% more Penta 3 doses than the same period of the previous year. Notice that there was a drop-up rate in the study, but that was not clear because the year before, those same facilities have a higher drop-up rate. Next slide, please. Okay, based on the M-shaped experience with MOH, MCSP endorsed to scale up EA-supported counties in the 3 counties that we are in. And based on the stakeholder meeting that was held at the end of the pilot phase, recommendations were made and those same recommendations were put in place. So for MCSP, it is not only the vaccinator who is referring mothers to the family planning provider for family planning, but the family planning provider also refer mother, if any, to the vaccinator if the child vaccine is not up to date. And unlike the pilot phase that we had, the vaccinators have supplementary ledger to track mothers referral. For MCSP, the vaccinators, they are using the registrar and the ledger to track mothers referral from family planning services. And there is a need for more work to be done to support so that the scale-up process, which is a good model, can go on. Next slide, please. Okay, what are the findings from the MCSP work done in family planning immunization approach? Clients and providers said that it was beneficial for the integrated services to go on. Even the mothers, because focal group discussion were held with the mother, and they also embraced the idea. They said it is a good initiative, so the integration should continue. But the referral process varies from facilities to facilities. In some of the areas, when the referral card is shown by the mother referral from family planning to EPR, that mother is called in, maybe in less than 5 minutes to attend to. Other places, the mother will be told to wait. And that might discourage the mother to go home because the essence of her visiting the facility was just for the child to be vaccinated. So the issue of privacy also. In Liberia, most of the vaccinations take place in the waiting place, where you have other clients, patients waiting. And the stigma with postpartum mother taking family planning is very high. So for them to accept the referral, at times if it is in the waiting place, it will require them want to accept the referral. But if it is in a place where we have only the vaccinator and the mother can easily accept the referral to go see the family planning provider. HR, human resource, is also a problem. At times you train the provider, but during the next visit, there is a turnover of staff. And again, in Liberia, we have only one CM or one person that is offering the maternal services in the OPD. That person is seeing the antenatal clients, the family planning, so there will be client who, if the vaccinator also referring people to that person to be served for family planning. And the social norms and on the use of postpartum family planning, this requires additional community engagement interventions. How can the community come in? What can we do in the community that will be aware that postpartum mother can use family planning, that baby mom can start taking family planning even before her baby walks? Next slide, please. Okay, what is our next step? We are doing a quantitative analysis of the service statistics that is right now going on for MCSP, and a more depth analysis is in progress. Recommendation for the next step include further adjustment and how to expand it, like doing the inline assessment of MCSP. When the family planning coordinator was contacted the Ministry of Health, she clearly stated that it would be better for us to expand to other counties and not only in limited facilities in the country. In that way, we'll not really see the impact. But if the intervention is spread in all the facilities, I think we have greater impact that people will realize what we are doing when it comes to family planning, immunization, integration. And we have further report of comprehensive findings that we can share with this group, but that will be at a later time that we'll do that. After all the analysis, the report, we are still available to share that with the group. Thank you very much.
Thank you so much, Niapu. Next, we'll hear from Dr. Riaz Mubarak Ali about experience of taking the lessons learned and experience from pilot programs to scale nationwide. Riaz is the country director of Pathfinder International Mozambique. Take it away, Riaz.
Thank you, Katie. Good morning and afternoon to everyone. Thank you. It's really a great pleasure to have this opportunity to actually share the experience for FP integration that started in Mozambique from a pilot, and then now it's in a national scale process. Can we go to the next slide, please? As an outline for this presentation, I'm just going to briefly talk about how the national guidelines came up, how we as Pathfinder has been supporting nationally at the MOH level and the provincial and district level to roll out, and some challenges and lessons that we have learned throughout the process. Next slide, please. So for the development of guidelines, it was through multiple project and organization that have been working in FP integration into other services, including immunization, that developed and created a body of evidence that was used to advocate within the MOH as well, aligned with the HIPS, to build the national guidelines. And this created this enabling environment by highlighting opportunities and all with the focus to avoid missing opportunities for family planning. So one of the experiences that was conducted in country was through MSHIP, and that was with the focus on postpartum systematic screening that was implemented in some of the districts in the country. And then what they realized was the increased uptake of FP methods for mothers that were coming to vaccination or immunization or to postnatal care using a tool for screening for family planning use or not. And they realized that this screening and use was not actually having any negative effects for women in using family planning. From another hand, as Pathfinder, we also have been supporting and working for with integration through two important projects. One was SKIP, that was an integrated program at the community level, and another one was a family planning flagship for USAID in Mozambique, ESDFPI. And in that one, we were integrating family planning services at the community level, and also we were doing that at health facility level. We were trying to maximize the opportunities within the health facility and at the community for those routine mobile brigades, where usually the core focus was only immunization at the community level to have completely vaccinated children. From another hand, we tried to plug in the family planning, and nationally there are two regular national health weeks with the aim for nutritional screening, deworming, and immunization. And we also have been working in trying to plug and integrate family planning, and within the facility in other services, including HIV care and treatment and others. Can we go to the next slide, please? So in this slide, what we are is just showing the history, how it happened. So with the evidence that were built through the different partners, we were able to develop a guidance that I'm going to share shortly, that we used in National Health Weeks to counsel and offer contraceptive services, including LARC. And with this, national guidelines were developed and was approved nationally by Ministry of Health late 2015, and in 2016 there was a phased approach with at least one selected health facility per district in country, and then in this year we were able to start with the scale-up in all eligible health facilities or wherever we have providers trained. So we can see the picture down is basically the national guideline snapshot, and this national guideline covers different areas. One of those are the rationale, goals, and the main objective to really have integration of FP services, including immunization, of course. The package for training for non-MCH nurses, because nationally the training for family planning has been with the focus for maternal and child health nurses. How to consider logistical aspect like commodities, how to ensure collocation of commodities, referrals, documentation, and reporting to ensure data quality and to have aggregation within the HMIS. Next slide, please. This slide just shows you the snapshot of what we have been able to develop as a guidance for National Health Weeks, or a mobile brigade that goes to a community level, where we do a screening for pregnancy, and then according to medical eligibility criteria, clients are counseled and screening for pills, injectables, implants, and IUDs, and based on that, recommendations are given, and depending on the conditions that are available at that specific spot, methods are provided, and usually implants are also, when privacy and all the conditions are there, also is available, are offered. And mostly for IUD, there is a referral for closest health facility, but recently, if there is a condition, IUDs can be also offered. Can we go to the next slide, please? So in this slide, this is just showing, this is also part of the national guidelines, it's showing the algorithm that is followed for screening a woman that is presenting in health facility for a healthy child consultation that we call. It's growth monitoring consultation or immunization services, and based on the postpartum status that that woman has, it goes through different screening process and counseled and offered a method. Can we go to the next slide, please? This table actually shows one of the main parts of the guidelines, where you can see on the left side we have different type of services listed, and then what type of services and methods can be provided depending on condition, if applicable, if not, and what is required. So basically, the screening can be offered in all the services. Information, education, and counseling are made available through, according to guidelines in all the services, and contraceptive methods are provided, or the service delivery is conducted depending on the condition that you have in that specific spot or service. And condoms are always offered and given as a method for dual protection as well. Can you go to the next slide, please? In this slide, this is basically that this is one of the very key part of the guideline, where we don't want to keep it away, showing that the importance of reporting, that all the data that are collected are aggregated in a daily summary form, and then into a monthly summary, and then it goes and feeds into the national HMIS system, so none of those data are missed. This is not still the perfect, it's a process ongoing, and improvements are being done. Can we go to the next slide, please? So how Pathfinder has been contributing to this process to Ministry of Health, and currently we are working and supporting the scale-up in urban settings and rural areas, and we are working in 4 provinces out of 11 provinces that Mozambique has, but we also provide this support at national level. So we have been working in technical updates, review meetings. We have been working in commodities in a way to proper forecast, request, and redirect if needed to ensure availability of commodities, train and provide mentorship for health facility staff, and that's basically considering MCH nurses and non-MCH nurses as they require more, because this was not something that was common to offer methods, specifically if we think about LARC. Demand generation at the community level to ensure that link between communities and facilities are really available and present, and this brings us to 2 different approaches. One is having health providers trained to offer services, but also sometimes having a CHW or community health workers placed at the health facility level in waiting areas, waiting rooms, or immunization area where they can definitely counsel through a group session or one-to-one session, and then for those ones that accepts a method, they can really go for services. Can we move to the next slide, please? In this slide, I'm just going to share some of the data. So in the first upper left graph, what we can see is that having a CHW can really impact the uptake of family planning services within the health facility. So it ranges depending on different facilities from 12 to almost 40% of clients that has accepted family planning in a facility. They really came from a referral from a community health worker. In the second graph on your right upper side, we can see the contribution of the different services that are non-family planning room. So the first one is immunization, is really contributing a lot with about 40%. We have HIV care and treatment and most at-risk consultation, where we have about 26%, but this is showing also that there is a lot of missed opportunities still there, and in adult outpatient care, it's only contributing with 19%, and there is also a very larger room to improve in that. When we come to the down slides, we can see that most of the methods that are offered in integrated or services are basically short-acting methods. As we can see, pills and injectables covering most of it, but we can see that IUD and implants tends to increase as much as they start to become more confident and as much as the mentorship to health providers increases. We have been seeing even providers such as dental care or dentists providing implants after a dental care service. Last slide, please. So what we have really learned throughout the process is the provider engagement is crucial to ensure that integration really takes place, because it tends to happen that providers feel that this can be overburden to their work, but once they are completely engaged, they start to really feel that it's greater to have ability to be one-stop shop provider, as earlier mentioned during this webinar. The second aspect that we realized was the leadership engagement and the ownership, and this has been critical. We learned that facilities where you have the head of the facilities during those shift periods asking about how many clients has been seen or received family planning services in different services, it starts to create some type of environment where everyone really starts to understand the importance of having this collaborative work. We also learned that sometimes commodities can be a challenge if we have stockouts, but you cannot only integrate the service by counseling, But if you want to offer methods, you should really invest in co-location, because once the client accepts, you are not trying to go to refer that client to a different room whenever it's possible. Having the methods in the same place makes it really happen, and you don't miss the opportunity. And of course, data collection and reporting is critical. It has been challenging to ensure that data from the different sites are really available, properly reported, because this can affect the forecasting and availability of commodities. This is just what I had to share with you, and thank you once again.
Great. Thank you so much to Riaz and to all of our presenters. So we've heard from Sean about the development of HIP briefs and tracking of evidence, from Rebecca on opportunities for integration and the importance of doing no harm to immunization services. On the ground, we've heard from Nyapu about lessons learned from initiating an integration program and generating evidence in Liberia, and from Riaz about how to take that evidence from these pilots and scale nationally. So for all attendees, please feel free to type your questions into the chat box. We'll start with a question for Sean from a colleague. How does a practice go from promising to proven?
Sorry, there was the automated voice blocked out part of the question. Could you repeat it?
Sure, absolutely. So the question is, how does a practice go from promising to proven?
Yeah, that's a great question. So we've had one practice that has made that transition. Mobile Outreach made that one a couple of years ago. Basically, it's about the evidence base, and as we accumulate more evidence in this area, so I would encourage you all that are working in this area to please publish your results. If you can't or don't want to publish them in a peer review journal, reports also count, as long as you're collecting data. It's clear the methods and the outcome measures that you're collecting. So anyway, to answer your question, it's basically as we get more evidence, we have a technical advisory group that looks at the evidence and determines whether we have sufficient evidence to say, yes, it is likely that if you implement this practice in a robust way, you will affect contraceptive use, or whatever the outcome measure we look at.
Great, thank you so much. And next we'll go to a question for Rebecca. What are some of the ways to monitor for negative effects on immunization? What types of indicators or information is most helpful?
Okay, thank you very much for that. What we used in Liberia, as Nyapu described, are a couple of the key indicators that we typically use for indicators. These are outcome measures. They are coverage and also dropout rates. Usually we monitor a first and a third dose of diphtheria, tetanus, pertussis containing vaccine. And then we look at the dropout between those first and third doses. And that dropout rate is a standard indicator for immunization. It is very easy to calculate, and it gives us a picture of the satisfaction with services and the continued utilization of them. Both types of data are routinely generated by every health center and on a monthly basis, and even as we also use DHS-produced data, we really do make use of the data that health facilities themselves produce every month.
Great, thank you so much. Next we have a couple questions from Sheila to Riaz. So who leads the partners collaboration process in the scale-up in Mozambique? What has the timetable been to go from 4 to 11 provinces? And what have some of the challenges been through scale-up?
Thank you, Katie. I think it's also great questions. First, I think the leading as I mentioned, the ownership from the government has been instrumental, and and all the process is being led through a technical working group for family planning that are based in the Ministry of Health, where all the partners that works with family planning, they convene in the same room, discussing and supporting the rollout. So everyone are aligned and with the same approach. So that technical working group is led by Minister of Health and currently co-chaired by Pathfinder. I also one of the question about data. I think that was if this all information is aggregated and we are able to. Yes, so there are tools for data collection that comes for the different services, informing that how much each service has contributed with a specific method, and if there are new or continual users. Although there is still a challenge that is not fully integrated in the DHIS2 HMIS system, because it has to be updated, but still on a paper data collection tools, it's still available on the summary forms. And then the scale-up process from 4 to it's not, of course, as we can expect, not very smooth. After the rollout of the national technical guidelines, it really required a greater commitment from leaders. So I'm talking about the directorates, the health facility heads. So whenever we had a really committed head, it was very faster, the rollout of the integration of family planning. In other places it was not so smooth, and then based on that there was a complete commitment at MOH level, and a second guidance was sent out. As I had in my third slide, it was showing that the technical guidelines covers 30 pages, but then a 8-pager was sent to each provincial health directorate to really ensure that the same message is passed to everyone. On top of that, in order to ensure very aligned intervention and approach, a national workshop is going to be held next week from 11 to 13 in order to have all the partners, provincial directorates and FP supervisors to really ensure the same approach and same implementation process. So again, I think the main challenge has been the commitment, and sometimes the availability of commodities as well.
Great, thank you so much. We have a couple related questions coming in for Liberia and for Mozambique about the tracking of referrals. So in both cases, does the system provide the ability to show FP uptake through direct access or alongside other services? How are referrals tracked? And several questions about sort of how one does that. So why don't we start with Niapu, and then Riaz, you can follow up. So Niapu, okay. Questions about referrals and tracking.
Thank you very much. As I said earlier, the referral tracking from the family planning, from the vaccinator to the family planning provider is done in the family planning ledger. Sorry, I didn't mention first because I said during the MSHA process, the vaccinator had a ledger that they used to record the names of the mother that were referring to the family planning provider. And we have a family planning ledger, and we have a symbol that if a woman is coming from the vaccinator to the family planning provider, you have a star placed in front of her name to show that she was referred from the vaccinator to the family planning. And if the family planning provider during the MCSP process, as I said, it was not only the vaccinator who was doing referral. The family planning provider also was doing referral if it was needed. And if referral is done from the family planning provider with a mother coming with a child for family planning services, the mother is coming for family planning services, and the child card is asked for, and the child is not up to date with the vaccine, the family planning provider could refer the mother to the vaccinator to be vaccinated. And in that column, we have the EPI in, EPI out. If she's the one referring the mother to carry the child for vaccinated, will be recorded under EPI out. But if she's the one receiving a mother in the family planning ledger for the mother to get family planning services, she's recorded in the EPI in with a stamp to her name, so that other users, new users coming from the community will be different from those that are coming from the vaccinator to the family planning provider.
Great. Thank you so much, Nyapu. And I just want to mention we are just about at our time right now. We've got some great questions coming in. Sean unfortunately has to go, but the rest of our presenters can stay on for a little longer. So thank you to any attendees who also have to go, but we'll continue for another 5 to 7 minutes or so with questions. Riaz, do you want to pick up about the
Sure. Referrals? And yes, sure. Thank you, Katie. I think the referral tracking has been something that is interesting everyone, and there are different approaches that are in place in Mozambique and that are really working. One is there is a simple form, referral form for all the services that are provided at the community level for different type of CHWs, cadres of CHWs, either if they are traditional birth attendants or other community health workers, and those are the forms developed by Ministry of Health, and they are the refers to the facilities, and then they can keep track on those referrals. On top of that, there are some of the interventions that we as Pathfinder, we are implementing in country. One is using a digital health technology where we are generating referrals through a specific code for family planning services, and then after counseling through a app where a pre-counseling is fully conducted for at the community level, and then there the client goes and to the health facility with a specific form to the health facility, and then once a week the community health workers, supervisors goes to the facilities and checks and confirms those referrals, and this brings us the information on the level of completion from the community counseling to the facility, the ones that reaches to the facilities and really receives the services or goes for services, not specifically talking about like method uptake per se, but that also can be seen through the logbook because the track is kept. The third approach that we are also is partnering with one of our implementing partners. We have started to use vouchers, either paper-based vouchers or electronic vouchers that generate codes, and then those can be those are presented at the health facility level, and once they really confirm the service, reaching the facility for a service, they are goes to the system. So we really have these three different mechanisms to account for these referrals, and the same applies for the mobile brigades or the outreach activities that are conducted from the health facility to the communities that are within that catchment area. When they go, they have a specific logbook where they use to provide services, and those are accounted as that. The only challenge that we still have is that, as I mentioned before, in national HMIS system, we still do not have a complete disaggregation on that, but at the provincial level and district level, they are still able to have that as a parallel information system to have the contribution on community work for family planning services uptake.
Great, thank you so much. Rebecca, I have another question for you. In settings where EPI is low, like in Ethiopia, as you showed, should immunization coverage first be increased before trying to integrate with FP, or can this be done simultaneously? Are there any experiences we can look to answer this question?
Very good question. I think the really important point is to have the discussions with between the immunization and family planning partners to understand not just what the current situation is, but also what is planned in the future. And also, I think it's very important to understand how critical the role is of the different partners, the immunization and family planning players in supporting the activity. I think back to the experience, excuse me, in Liberia, where at that time with MCHIP, 2011 or so, the coverage for DTP3 was only about 47%. Not a great situation, not terribly conducive to serve as a platform. On the other hand, there was strong political will on the part of the Ministry of Health at high levels to say, look, let's make sure we use every opportunity we have to try to improve services for the women and children that we are trying to serve. So it was not an ideal set of circumstances. It was not, what we would really hope for. But again, the political will was there, and that was really critical for making that activity be able to move forward. Thank you.
Okay, great. And then we have a question from a colleague in Burkina Faso, also for you, Rebecca, or others. Are there any specific interventions that can be implemented in order to reduce the risk of mothers avoiding immunization services due to integration with family planning?
I'm sorry, the phone just kind of cut out for a second there.
Okay.
Could you repeat the question?
Absolutely. So any specific interventions that can be implemented to reduce the risk of mothers avoiding immunization because it's integrated with family planning?
Well, I think, again, some of the experience from Liberia is very important to consider. You'll recall from Nyapu's presentation that the qualitative research indicated that there was concern and some stigma associated with women seeking family planning before their child was old enough to walk. And the upshot of that was that we really focused in our intervention on trying to make sure that there was some sort of confidentiality for those women, both within facilities, especially facilities that did not have, in which all services were provided in a big open area. We provided some what were called privacy screens, just constructed out of wood and fabric. Those screens were appealing both to the vaccinators and to the family planning providers. And we also made a decision to focus on integrated services within fixed facilities rather than during outreach services, because during outreach services there was not going to be any opportunity for confidentiality. And I think this underscores the importance of conducting the formative research or in some way or other seeking the input and the views of the mothers who are to be served as well as of the health workers themselves. So I think that's the really important thing to do, is to seek their input in design of interventions.
Okay, great. Riaz, do you have a very brief comment on this, and then we'll go to one last question and then close.
Sure, thank you. No, I just wanted to highlight that two aspects has been showing critical. One is a good counseling process during those immunization areas, and secondly, having a community health worker or based at the health facility to provide those group sessions, and then for those that shows more interest to provide one-to-one counseling separately with more privacy has shown that it works. Thank you.
Okay, great. And then we have a question from our colleague Rodolfo in Latin America, and a somewhat related one from our colleague Falake as well. So when looking across, can we calculate, this is for all presenters, can we calculate what the demand is? So what, in order to make sure that the methods are available. And Falake's question related to that is, have we seen any trends with the type of method that women who access integrated services are preferring? So how do we sort of calculate and anticipate demand, and have we seen any trends in that? Nyapu, would you like to start?
Yes, I think the demand will be calculated if we work closely with with the Ministry of Health, who will help us in forecasting our contraceptive need, and also involve other partners that are in family planning, not only in family planning, even immunization, we have to be done together, because we are talking about integrating services together. So I think that, and also working with the community, and we work closer with the community, and as Rebecca mentioned, that the political will have to be there before we can succeed. If the political will is not there, they are not buying in, it will be difficult for us. But if all of us are working together, I think we will be able to succeed. Oh, the second one. The second part of that question, can you please go over it?
Any particular trends, like do we notice more women picking implants or injectables or pills? Is there a preferred method among women?
Most of the women accessing the facility could prefer the injectable. The injectable or the implant.
Great. Well, thank you all so much, and we've got a bunch more very interesting questions. I'm sorry to anyone who didn't get their question answered today. The recording will be available and presentations along with a transcript of all the questions. So if your question wasn't answered today, we'll try and get an answer and post that with all of the materials. In particular, I see there's one question about how can the findings of integrated service delivery be integrated more broadly into healthcare packages for universal healthcare. And that is a question that we have also been kicking around in the FP Immunization Working Group. So if you want to know more information or get involved, please go there and we can continue the discussion. And lastly, I'd just like to give a huge thanks to all of our presenters and to IBP. While he has not been vocal today, I'd like to do a special shout out to Ados May, who's done a wonderful job of helping pull this together and keep everything running smoothly behind the scenes. So thank you all so much for your interest and have a wonderful day.